Okay, we are online. Hello to everybody. Welcome to today's webinar. Thank you so much for joining tonight. The topic of today is 2 paradigms of neurofeedback, frequency band training and infra-low frequency. And yeah, that's what we are going to discuss today. My name is Viola and I'm working in corporate communications for BMedic. Our speaker today is Olga Kara. She's going to introduce herself in a minute. And then I'm just going to say, after that, I'm going to say a few more organizational things, and then we get right into the presentation. So yeah, Olga, if you want to say a few words about yourself, please.
Thank you, Viola. So my name is Olga Kara, as you maybe saw already during the description of this webinar. And I'm working with BMedic for many years, and I'm dealing with frequency-based training and ELF modality. That's why I'm bringing today this discussion. And a little bit more about me. So I'm a neurobiologist from the beginning, but I also specialized in psychology, in psychotherapy, and so I'm doing different kind of work, like brain mapping, and I'm running my own clinic in Finland. So there's many things what I'm involved with. And today webinar, it's about my own understanding of the different approaches in neurofeedback. And also this webinar is introductory webinar for our course. So this is a little bit about me.
Okay, perfect. So the webinar should take around 1 hour. So first, Olga is going to say a few words and make a presentation. And in the end, we are going to have a Q&A session. But Olga told me you can also ask questions in between. So I am going to have an eye on the chat and see if there are any questions. And I think we get right into it. Olga.
First of all, thank you everyone for coming tonight for this short webinar. And because I really would like to discuss more with all our colleagues, especially who are using BMedic equipment. And I think it's like an open question still exist about this topic. So if you're really interested in this, we can maybe discuss more in another type of webinars. Maybe somebody else can also share their experience. But also this is an introductory webinar, as I already mentioned, for our one-day practical training course. So in the practical training course, we are going to show you how to work with frequency-based neurofeedback. So there's going to be actual training, like not physical through web, but still. But today it's more about theoretical background, how we can think about these 2 different paradigms and how we can integrate them. Okay, so shall we begin now? Yes, I will start from, again, definition of neurofeedback. We talk neurofeedback all the time. We hear neurofeedback all the time because we are working in this field. And of course, we have this appraisal that everybody knows what it means. Unfortunately not, and still many of our customers, they were surprised when they realized that there are some methods that can help them with their very difficult cases. And also there's a discussion, ongoing discussion, which method is better, what we should use. Should it be neurofeedback based on the frequency, or should we use only ELF? And if there is any specific reason why we shouldn't use one or another method, and also the question coming all the time, can we combine both methods in one client? And that's the reason why we decided to create this webinar also and the course, just to give you more information about the possibilities. With BMedic equipment, we have possibility to train frequency-based with BMedic equipment. And there is different level of that. For example, those of you who are using the black box, you have a possibility to train 1 channel or 2 channel ELF neurofeedback, but also those people who has another type of amplifier, you have possibility to train other types of frequency-based neurofeedback as well. Okay, but now I will talk about clinical choices and about goals, which one is better or which model should we use in what kind of case. And I will try to explain you main idea and then later on give you some real recommendations about that. And this I already mentioned. So this is introductory comparative. So we try to compare 2 methods, understand what's the difference between them, and what type of model on the base of each method, and how we can integrate the different approaches in thinking about the brain work. Now I start with definition. And I will tell you that neurofeedback is non-invasive closed-loop BCI system, BCI brain-computer interface. We are not often telling about this, but it's also a very important assumption. So brain-computer interface is like a bigger field. And actually, if you are interested really in neurofeedback and all this closed-loop BCI system, maybe some of you doing some research work, you can also look more about what BCI systems are, what they bring, and how we can integrate their way of thinking into our understanding of neurofeedback. Then also neurofeedback is a type of biofeedback. And we are going to talk about each of these assumptions, what I'm just naming now. What is the most important thing, what we also should all understand, that we are dealing with physiological signals from the brain. Doesn't matter what we record. We're working in frequency-based neurofeedback or infra-low frequency neurofeedback. It's still physiological signals from the brain. We continuously monitoring them, right? And we translate them into immediate sensory feedback. Users in these approaches, in all of them actually, biofeedback, neurofeedback, or in traditional BCI systems, all of them learn to modulate their functional state. And when we talk about functional states, we can talk about like neural states, or we can talk about physiological states, or emotional states, or attentional states, etc. So we can really split this modulation of functional state into subcategories, depending on what we are dealing with and what we are interested in. And learning occurs via operant conditioning and self-regulation mechanisms. Actually, it doesn't matter what type of neurofeedback we are using, we still learning via operant conditioning just because something presented to you from the screen. So there is some positive or negative reinforcement going on all the time. And of course, to change the functional state or to adjust functional state or to modulate it, we need to imply also some self-regulation mechanisms. So all these things is very important. I hope you can see the slide. Sorry, it's small. I tried to make this presentation shorter. Therefore, I try to combine some slides in one. This slide is just represent 2 different approaches. So known for you neurofeedback. Now I don't make a division between frequency-based neurofeedback and ELF neurofeedback. Let's say neurofeedback, and then brain-computer interface. So the difference between, there is a difference and similarity. In neurofeedback, primary goal is self-regulation of the brain. and it's provide immediate feedback, and feedback target in this case, it's user. So we try to target ourselves by visual, auditory, sensory feedback, any kind. And then learning focus into internal state, into something that change inside our own body. And then in this case, brain is our signal source and at the same time target. Output is sensory feedback, something change in feelings, or if you work in ELF format, right? But actually also if you work in frequency-based modality, there is also some changes in how the person feel themselves. Output affect internal states, not the external environment. In case of BCI, like classic brain-computer interface, they was using mostly so-called event-related potentials, but it's not only. They also use frequencies. So by modulating the frequencies, we can also control some device that we need to control, like, for example, a robotic arm, or we can control some system that can stimulate somebody's muscle in case if the people paralyzed, for example. And by this, we can reintegrate the brain and the distant part of the body. So it's also brain-computer interface system. So the idea is more or less the same. People have to create certain activity in the brain to be able to control device. In the old neurofeedback systems, when we don't have so beautiful games like now, it was very, very simple representation. Like it could be only some music that abruptly change, or it can be, for example, some bar that we have to keep on certain level. And actually, that is exactly like brain-computer interface working. So neurofeedback is one part of this whole big field. And there's a lot of things going on. It's so many development inside, and I'm really interested in this part, so I will not talk too much about this. But it's important for us to understand that we can control not just our body, but by controlling ourselves, we can control something external. Neurofeedback is a type of biofeedback. It's clear, right? Here, the difference is that if you talk about biofeedback, main goal is to learn the body functions. And we use our physiological signals, not from the brain, but from other parts, like heart rate, breathing, muscle tension, skin conductance. Actually, all these things is also possible to do with BMedic device. But it's another webinar for that. Feedback is given directly to the user. And in this case, again, the body is our signal source. And at the same time, body is target for the training. So by changing the breathing, we can change our heart rate variability. We can change some parameters of that. And by that, we also can acquire certain state. We can also control our muscle tension. Even before people was unaware of that, during biofeedback training, they actually learn to control their muscle tone. This is examples like what it means, heart rate variability training or breathing biofeedback, what type of signals, how they looks like for the provider or for the trainer. And learning happens exactly in the same time like in any type of neurofeedback, observing body signal, adjusting, in this case, breathing or posture or relaxation, and then we reinforce desired response. So here we don't target brain signal directly, but to be able to control own physiological signals like heart rate, breathing, muscle tone, etc., you have to be aware of what's going on in the body, and therefore you have to change your brain states also. So it's kind of indirectly affecting our brain functions. And that's why also we're teaching quite often in our courses, and we promote our users to add into the practice a combi sensor. Okay, it's not exactly a biofeedback device, but it still provides you quite a lot of information about what happened on the physiological level, on the body level. So learning happened through feedback. And you know that our brain is all the time creating some assumptions, what's going to happen next. So this called anticipation. And we are, if we're looking at the screen and feedback matches the expectation what our brain creates, our brain reinforces these patterns. If there's some mismatch, then we need to add some so-called error system, and our brain try to correct our own, whatever we're doing at this moment, our own action, and change the state or feelings, not exactly like this, but anyway, it changed its state to more appropriate, that it matched some expectation. And it is very, very important to understand. We also have sometimes some people who has problem with anticipation, problem with error regulation system, and they couldn't adjust their behavior. It's something that it's the core function of self-regulation. If these systems, they are not working properly, people struggle to self-regulate. Another thing that we also have to discuss if we talk about frequency-based neurofeedback and ELF neurofeedback, it's what type of learning we are using, explicit or implicit. Explicit, it's when we can explain, right, what we're doing, what we're feeling. Like if we talk about biofeedback, if you're doing some, for example, biofeedback, it's quite straightforward, right? So you just, by changing the breathing pattern, you, for example, start breathing slowly, you know that something changing on the screen. And implicit is something that you can actually describe, something changed. And that's exactly what happened during ELF, mostly. In the frequency-based neurofeedback, it's still quite a lot of component of explicit, because we can more or less explain the people what they may experience or what they should do. Or sometimes we can say, now you have to focus, and then you will see nice clean picture, for example. But in case of ELF, we can say like this. So it's more implicit, it's in unconscious level happen. So what's the main difference is between this all? If you talk about biofeedback and neurofeedback, goal is self-regulation. Only difference that in biofeedback, it's like generally self-regulation. In neurofeedback is more or less, we are trying to target brain self-regulation. And also, if you talk about biofeedback, it's more general status. But about neurofeedback, it's more like we're targeting specific brain system, right? So we are not taking signal from all brain. We have a certain place, how we place the electrodes. We have protocols. And by these protocols, we try to target specific brain systems. And if you talk about brain-computer interface, the difference between this, it's that we target device. We learn how we can operate and device just by thinking about this or by applying certain strategies in our brain. And about learning, as I already say, biofeedback, it's totally explicit, while neurofeedback, it's more implicit. Even frequency-based neurofeedback, there's a huge component of implicit learning as well. While brain-computer interface is more task-based. Okay. Now, and this is the very important part, when we talk about ELF or brain-computer interface or frequency-based neurofeedback, we talk about neurofeedback models. And actually in the market, there is quite a lot of different systems. And sometimes we get this kind of question, like, what's the difference between different systems? I'm not going to give you overview of the system because there are really many of them. Some of them people just develop, some of them are known, some of them known, doesn't matter. But the main idea is the different models try to imply the different ideas about what is the most effective way to learn through neurofeedback. And here we can use signal type, feedback target, learning paradigm, clinical approach, or technical complexity. And I will tell a little bit about each of these categories. For example, when we talk about the signal type, we can use EEG. And that's what we are doing if we're doing neurofeedback. Then there is another type of signals, it's FNIRS. In this kind, we try to target hemodynamic in the brain. And the same thing is fMRI, they also target hemodynamic in the brain. What's the difference between them and EEG? They work slower and it's more expensive devices. So it's not exactly the same signal type what we used to expect during neurofeedback trainings. And hybrid devices, they are also now presented mostly still on the research level, when we can try to simultaneously get signals from biofeedback and neurofeedback. And actually fMRI is also not a real clinical method. It's still quite a lot done only on the research level. So in universities, they try to use it for research purposes. Okay, the next thing what we have to also understand is feedback target. What we can target during neurofeedback. We can use frequency, and in this case, we can say, the person has attention deficit disorder, and usually these people have increased theta in the frontal areas, or increased alpha in the frontal areas. Or there is also some beta variant, they can have increased beta in certain areas. What this gives us as practitioners? It means that we can target specific band. We can say, okay, now if we reduce the amount of theta in the frontal area and increase the amount of beta in the same area, probably we are going to have less inattention, right? Another thing to target is spatial or source-based approach. And this is so-called S-Loretta. Probably you heard about that. In this case, we apply full electrocap on the scalp. And then, because you already have QEEG analysis and you already know what type of, which area you are targeting, so you have coordinates, you can add into the system these coordinates, and the system will try to find the precise area in the brain what you need to work with. About how much it give, how much benefits you get from this kind of training, it's again another discussion, but still this method exists. Connectivity based. In this case, we can target relationships between different brain regions. And again, if we able to do some brain mapping, of course, we can create connectivity maps, and we can see that, for example, P4 and T4 has low connectivity. There is not enough communication between these two sides. So if we apply electrodes, we try to improve communication between this area, and therefore probably we are going to have less symptoms for this client. Another target is state-based. It means that we target global brain states like relaxation, attention, etc. So you can imagine that, for example, in ELF, we are going to work more with connectivity-based targets and with state-based targets, because we are trying to target global brain states. We are not targeting specific part of the brain, just that we can do, for example, an S. Loretta with Tolerac coordinates. We don't need that. We have another logic, but we are going to talk about that. Learning paradigm, again, we already mentioned it, operant conditioning for all neurofeedback. But then we have also implicit learning without specific strategies, or explicit, or also adaptive learning. This is interesting approach when the system adjusts threshold based on performance. And if someone really learning very quickly, so the system can make it more complicated, right? So it will be adjusted. In this case, you are not so boring to do it, and also you learn more effectively. Or if someone can't meet the requirements, so then threshold can go down. Again, just to be in line with the current situation with particular person. Clinical approach. We have symptom-oriented clinical approach when we target specific symptoms like attention anxiety or something else, or OCD, or post-traumatic stress disorder, whatever. Then we have a disorder-specified protocol. It's specific protocols for clinical condition. What I'm talking is, for example, so-called theta-beta ratio training. You know that it got recognition from FDA as a possible treatment strategy for attention deficit disorder. So this will be disorder-specific protocol. Then we have individualized or personalized protocols. Then you need to create individual brain profile, and it can be even related potential, QEG. Usually it's done like this. Probably also it's possible to use by doing maps in functional MRI or something like this, but usually it's QEG or ERP, and performance-oriented. So then in this case, we focus on optimization rather than pathology. And it's used for, let's say, healthy people, more or less healthy people who just need to improve certain functions. Like you maybe heard before that it was some research paper published that for young surgeons, they tried to do some neurofeedback to improve their ability to be very precise with manipulations when they do some training on operation. And technical complexity is also one thing. It can be quite low complexity. In this case, we can use single channel EEG with fixed threshold, or it can be more complicated when we use few channels of EEG and then adaptive threshold, for example, or we can do very, very complex like source localization, like S. Loretta, plus connectivity, plus real time, and this is usually used also in fMRI research. And this, of course, can be even more complicated when we do some multimodal system and we apply some machine learning. They are not exist in the market, this kind of high and very high level of technical complexity, but they do exist on the research level at the universities. Types of neurofeedback models. Conventional frequency-based neurofeedback. Conventional just because it's known and it was the first one that was introduced, and we're using it for like from 60s almost. Infra-low frequency neurofeedback, slow cortical potential, connectivity coherence model. Then we have normative database driven model or Z-score neurofeedback. This one also exists. When it continuously compare the data from your client with some normative database, calculate Z-score, and based on this kind of assumption and very complex calculation, it provides feedback. Then source localization, S-Loretta, hemodynamic-based fMRI and FNIRS. So there's different models that can be used for neurofeedback. But these models, they're not just different from what they train. The main idea under that is how they understand and define the brain itself. For example, we can see the brain as a set of signals or rhythms. In this case, of course, we can increase or decrease something, and that's how we can explain our behavior, right? Or our feeling or our symptom. Or it can be seen as a collection of regions or networks that can be activated or balanced. Or it can be seen as a dynamic system that learns and adapts through feedback. So all this different understanding of the brain, they are in the foundation of different approaches what we use in neurofeedback. How the neurofeedback can shape our clinical decision. So the clinician have to make a decision every time when we start working with certain client and his symptoms. The model will determine what is considered the relevant information for this particular neurofeedback model. Like if we're talking about signal-based model or frequency-based neurofeedback, we will focus on EEG frequencies and threshold. We need QEEG assessment. Without QEEG, it's impossible to work almost. Of course, you can make some assumptions, but still they rely on brain mapping. Region network-based network, in this case, clinician will focus on brain areas or connectivity. In state-based models, we will focus on global regulation and stability. And if we talk about symptom-oriented models, then we will focus on behavioral and subjective changes. And probably you by yourself already can have some idea what we are talking about if we talk about frequency-based neurofeedback or ELF, right? In ELF, we work in state-based models and symptoms-oriented models. We are taking care about subjective changes. We focus on that. We're looking all the time. We're asking our clients. And state-based models, we focus on global regulation and stability. Yet, of course, we also thinking about brain areas and connectivity. Okay, and then also different models differ in when we discuss about what is it working or not, if this method is really working or not. Do we get success or we don't get success? How we can see it. In signal model, we can say that signal normalization or change in frequency, probably we are on the good track. In another model, we can say that if we improve stability or flexibility in the brain, so then we're also in the good area. Then symptom reduction and functional improvement, of course, will be for us an indication of that method working. And of course, if you have some increased regulation capacity and tolerance of stress, we say, yes, we are doing something good. Examples, maybe make a little more clear understanding of what I'm talking about. Let's say we use frequency-based neurofeedback and we apply signal-based model. Our goal in this case, signal normalization. We have QEEG. We know that there is some difference in EEG. Clinician will look at ratios, theta beta, theta alpha, etc. And client will try to reduce, for example, high beta activity in case if they have a high level of anxiety or chronic pain. Over session, this high beta will decrease, and we can say it's working if signal moves into desired direction. But at the same time, a person may not feel anything still. And sometimes we can normalize the brain, let's say frequency, but the symptoms still there. How we know that it's not working? If EEG signal do not change, but clients feel differently. But for the signal-based model, we still will think that we still need to do some improvements in EEG. Okay. If we talk about state-based model, we try to target stability or flexibility. Both is very important. I can just say a couple words. Like, for example, to be able to adapt to whatever going on in our life, we need to be flexible enough. And many people who has certain conditions, they just stuck in their state, like in post-traumatic stress disorder, for example, or people with autistic spectrum disorder, they have a problem to switch between different tasks and they have very low level of flexibility. They are very rigid in their brain functioning. But at the same time, there can be another situation when people, they have very unstable brain. So they cannot fix on anything. So they're changing all the time, and it's also create problems. So we need both stability and flexibility. So we are going to look at overall regulation, resilience, and stability. And client initially may feel overwhelmed after session. That happens sometimes in ELF neurofeedback, you all know. But over time, they recover faster and feel more balanced. And we will consider that this model working if client become more stable, more flexible, even if EEG targets is not so clearly showing us some difference. Okay, but we say it's not working if session consistently destabilize the client, if the client cannot function normally after the session, not maybe immediately, but you continue working with them and there is still not improving anything. Clinical model, of course, for clinician in this case, symptom is most important part, and they look at daily functioning of the client. An example is, for example, ADHD person could show better focus at work, and sleep and emotional regulation improve. In this case, we say, yes, it's working, but not working if no functional improvement despite any kind of EEG changes. So in this case, a person will look mostly on symptoms. Symptoms is very important. And the regulation model will tell us about increased tolerance and regulation capacity. So clinician will look at how client tolerates stress and how they can tolerate changes. And for example, trauma client can stay present longer without dissociation. In this case, we say, yes, it's working, this model, we're doing the good job. Or not working if training exceeds the client tolerance and causes some overloads. So the different models bring us different ideas how to look at client and what type of adjustment we should do and what type of method we should use. Okay, So frequency-based training at a spectral model of brain function, you all know that. And here we say that EEG change will provide symptom change. We still use symptoms, diagnose, and but we will target specific frequencies. Reduce theta for inattention, increase SMR for hyperarousal, etc. In neurofeedback, in ILF neurofeedback, we talk about self-regulation model, and here we target the core nervous system regulation, not performance enhancement. So we don't need to train a certain skill. We train the state. We try to achieve some stabilization of arousal. We try to achieve shift in baseline state toward a more functional range. We engage autonomic and affective regulation, not so much cognitive control, because we never give this kind of clear instruction to our clients. And then we use implicit learning. This is just a little bit more about neurofeedback and arousal stability. You all know that. So arousal is baseline activation level of the nervous system. And here we integrate, arousal integrate all, like cortical activation, autonomic balance, emotional reactivity, or sensory responsiveness. And you all experience probably in your daily practice that your client with autistic spectrum disorder will be hyper aware of the sensory signals. They're hypersensitive, basically. And arousal also, it's alertness, it's system readiness to respond to any kind of demand. So without certain level of arousal, we are not functioning. And this is also, you can see in your daily practice, some people, they have too low arousal, and you need to adjust the system so that they can feel better. Okay. So arousal instability or dysregulation, hyper or hyperarousal, these are state instabilities. They are not fixed personal traits. I already mentioned it. How does the brain learn in different modalities? So in frequency-based explicit and operant, in ELF more implicit and experiential. So brain respond to reinforcement and frequency-based, and change occur beneath awareness. So it's very unconsciousness change what happened during the ELF. Okay. Also important that in frequency-based neurofeedback, brain will learn control over oscillation, but in ELF, brain is non-linear, self-organizing system. It's that how we see it from this modality. And stability emerges from slow regulation. Regulation comes before optimization. Okay, success criteria also different between two modalities. In frequency-based symptom improvements, in ELF more stability. EEG metrics move correctly in frequency-based, and better emotional tolerance in ELF. Frequency-based focus calm performance in ELF, improved sleep and reduced reactivity. If we talk about discomfort, so in frequency-based, it's more or less inappropriate sight or montage, and some adjustments will be technical, but in ELF, it's risk of destabilization, and if you move too fast to some new frequency, or we change too much, risk of destabilization, I already say, and adjustment will be slow. Okay, now, why frequency-based working better for neurological case, right? Because neurological condition often seen as, let's say, broken machine, if I can say like this. because we can have some clear, measurable EEG abnormalities. They come from structural or metabolic injuries, and they have some focal or generalized changes in EEG, like reduced alpha or excess of deficient beta, or we have spikes in EEG. And in this case, we will think that we need to rebalance this broken machine. And frequency-based training will doing just fine in these cases, and even better than ELF. ELF will work better for psychiatric cases. Why is that? Because when we talk about psychiatric condition, it's usually network dysregulation more likely than any focal damage. Of course, focal damage can also bring some psychiatric condition. This is different story, but generally, let's say, in most of psychiatric cases, we cannot see very clear and understandable pattern in the brain. And then dysregulation can be in default mode network, limbic prefrontal connectivity, or we can have some autonomic nervous system instability, hyper or hyperarousal, poor stress recovery, developmental and attachment-related adaptation, or sometimes you have just normal-looking EEG spectra and people still presented with symptoms and they have even psychiatric diagnosis. So in this case, ELF working better because psychiatric condition will involve unstable operating systems. So we need to work on, let's say, not on the mechanical level, but more on the software level. And ELF helps stabilize the system rather than will tune individual components. And here some example, like if we talk about stroke, traumatic brain injury, or epilepsy, and the primary dysfunction in this case is structural or metabolic, then frequency-based approach working just fine. Parkinson, MC, again, we have oscillatory abnormalities, and again, frequency-based will work perfectly for these cases. But if we talk about post-traumatic stress disorder or anxiety, there is some arousal dysregulation, there is some like I told you, this network dysregulation, default mode network, etc. In this case, ELF is much more, let's say, much more clever choice for this type of clients. If we talk about depression, it's create network instabilities, and we also use ELF. In developmental trauma, autonomic imbalance, and it's also ELF. Of course, we can have mixed situation. We could have some psychiatric patient with post-traumatic with traumatic brain injury situation, or we can have some person with psychiatric case and stroke or epilepsy, whatever. In this case, we may benefit from both, actually, from ELF and frequency-based neurofeedback. So there is no question about which method is better. It's just we are talking about when and how we should integrate both methods. And it's possible to integrate this method. There is no such big risk for that. It's just you have to keep in mind the model, what you are working with, and also the benefit for your client. Because if you're working with person with traumatic brain injury who need mostly frequency-based and you will work with ELF, he will still improve, but improvement will be much slower than in case if you start also adding some frequency-based neurofeedback. So I invite you all to our next round. So 1-day practical training. We will have some more information about clinical decisions, and we will demonstrate you basically how to do it, how to open the program, what to do, and how to set parameters, how to start working with this. Actually, frequency-based is really easy. It's not something unbelievably complicated. I think ELF in many ways is more complicated approach than frequency-based. Okay.
I think that's it for tonight. Okay, so thank you everybody for joining tonight, and hope to see you all soon, and have a good night. Thank you,
Thank you
Olga.
all. Thank you.
Bye.
Bye-bye.